In pediatric practice, mosquito repellent presents a dual clinical objective. The goal is to prevent vector-borne illnesses without inducing accidental chemical toxicity. Standard dermal application is safe. The severe pediatric morbidity we see in emergency departments arises almost exclusively from incorrect application or accidental exposure. Mitigating this risk requires the practitioner to take an active role through proactive, age-stratified parental counseling. Gold standard chemical baseline for pediatric use is DEET. Looking at this clinical safety reference, we see the precise constraints for DEET. Safe for infants over 2 months, limited to 10 to 30% concentration. Directly below is Picaridin, a well-tolerated alternative with the exact same 2-month threshold. Picaridin matches DEET in overall efficacy, but frequently presents with less localized skin irritation. Continuing down the chart, the safety threshold shifts significantly for IR3535. This agent requires an older patient baseline, restricted entirely to infants 6 months of age and older. Finally, we have the botanical alternative most commonly requested by parents, oil of lemon eucalyptus, or PMD. There is a strict clinical contraindication for OLE in children under 3 years of age. This restriction is driven by a high risk of severe allergic skin reactions associated with the active compound. These age thresholds act as non-negotiable pharmacological constraints, not flexible pediatric guidelines. Despite strict prescribing baselines, practitioners must be prepared for the clinical presentation of accidental exposures. Localized toxicity typically begins with dermal overexposure. The mechanism here is straightforward: heavy oversaturation of the chemical, or application that becomes trapped and concentrated under tight clothing. This section of the reference chart outlines the specific presenting signs: visible erythema, intense burning, and in rare cases, numbness. The immediate pre-hospital first aid protocol requires removing contaminated garments, followed by a continuous 15 to 20-minute wash with soap and water. Parents must be explicitly warned against harsh mechanical scrubbing, which only increases blood flow and exacerbates dermal absorption of the chemical. When exposure shifts to the ocular route, the toxidrome presents with severe burning, excessive lacrimation, and blurred vision. The response protocol here is a continuous 15 to 20-minute irrigation with clean water. A crucial clinical constraint applies here. Parents must not administer any over-the-counter ophthalmic drops prior to a formal physician consult. Localized exposures require aggressive, sustained dilution and mechanical removal. The introduction of secondary chemical agents is strictly avoided. Beyond localized reactions, we face the immediate threat of systemic exposure profiles. The primary vectors for inhalation toxicity are environmental, specifically the use of mosquito coils, heated vaporizers, or aerosol sprays within enclosed, poorly ventilated spaces. This chart highlights the acute respiratory toxidrome presentation: severe coughing, onset of wheezing, and acute chest tightness. Immediate environmental triage requires extracting the pediatric patient to fresh air and loosening any restrictive clothing to ease respiratory effort. The clinical threshold for hospital escalation is clear. If breathing difficulty persists after relocation, immediate ER transport is required. Inhalation exposures closely mimic acute asthma exacerbations. They demand constant monitoring for rapid respiratory decline. The absolute critical climax of the pediatric triage protocol is accidental ingestion. The most hazardous product format on the market is the liquid vaporizer refill. These liquids contain highly concentrated pyrethroids suspended in volatile hydrocarbons. Returning to the chart, the ingestion toxidrome is an extreme emergency. The cascade moves aggressively from emesis to severe central nervous system depression, drowsiness, and seizures. This brings us to the critical pre-hospital errors made by parents and first responders. The first absolute contraindication: do not induce emesis under any circumstances. The second absolute contraindication: do not administer diluting fluids like milk or water. The pathophysiological mechanism of mortality explains why. Vomiting or fluid dilution significantly increases the risk of hydrocarbon aspiration into the lungs, causing a rapidly fatal pneumonitis. The only correct protocol is to maintain the patient in an upright posture, keep them calm, immediately contact poison control, and initiate rapid medical transport. In severe ingestions, standard layperson first aid is actively lethal. Rapid, hands-off medical escalation is the only viable path. To prevent these clinical emergencies, we must prioritize proactive parental counseling. Counsel parents on the correct mechanical application process. Adults must apply the chemical to their own hands first and then transfer it to the child's skin. Emphasize strict avoidance of the child's hands, as well as the periorbital and perioral areas, to prevent secondary ingestion. Finally, this graphic highlights a specific, highly common clinical pitfall: combination products. Products that mix sunscreen and repellent agents pose a distinct pharmacokinetic danger. Sunscreen inherently requires high-frequency reapplication. Applying a combination product at that same frequency causes a dangerous toxic accumulation of the repellent agent on the skin. Clinicians must reinforce the necessity of strict once-daily application limits for repellents, followed by immediate washing upon returning indoors.